passion for service to women in the area of minimally invasive gynecological surgery and robotics of fibroid care. Please welcome Dr. Wechter.
Well, thank you. Can you all hear me okay? How about this? Is that better? Okay. 70 to 80% of women will have fibroids by age 50. So that's most of us in this room, most of us, making this a highly relevant topic. But what are fibroids? How do we know we have them? What symptoms do they cause? Where do they come from? And how do we treat them? So that's what we're here to discuss. Well, I should give you a warning. So there will be pictures. I think they're beautiful because they're anatomy. I will warn you in case you don't or you want to look down. I know everybody's eating, so, but I'll use them to illustrate what I'm talking about. I am a GYN surgeon. I'm a laparoscopist. I don't need to do that. I do robotic surgery, and I do research on fibroids and surgical outcomes. So this is one of my passions, and I'm really happy to be here speaking with you today, and I really appreciate that everyone's here to listen. Okay, so picture. This is a normal uterus, okay? Right here at the top. Can you see that? So a normal uterus, if you look at your fist, if everybody looks at their fist, should be about the size of your fist. And it's a muscular bag. It's amazing. It does incredible things, but it's a bag. And its job is to hold pregnancies. And its spare time, it gets ready for a pregnancy. And if a pregnancy doesn't come, it cleans house with a period every month. Okay? But normal size. And what you can also see in this picture are normal, nice looking ovaries behind and the back of the uterus here. I'm going to show you another picture. Ready? So this is a fibroid uterus. You can see my hand at the top of the picture here, so you can see the scale. This is about the size of a full-term pregnancy. Okay? This picture has a couple things that will help me illustrate. Number one, a uterus that knows how to make fibroids will usually make more than one, and on average 7. They can be any size. So in this picture, you see tiny ones about the size of a pea, and huge ones the size of maybe a cantaloupe. This one down here is a pretty classic appearance for what a fibroid looks like. It's only got a little bit of tissue covering it. A fibroid looks like a potato. It's generally round, it's white, it's firm. Okay, enough with pictures for a minute. So what are uterine fibroids? They're benign tumors of uterine muscle. And that's the good news, is that they're almost never a cancer. Less than 0.1% of the time will something that looks like a fibroid actually be a cancer or a sarcoma. They're very common. 70 to 80% of us by age 50, a third of reproductive age women. If you were to have a room full of women who had come because they had heavy or painful long periods, about 40% or nearly half of those women would have fibroids. It's the most common reason for hysterectomy in the United States, outnumbering all hysterectomies for GYN cancers combined. So around 250,000 every year. And these grow in response to our natural hormones, estrogen and progesterone. So it's hard to escape them during your reproductive years. What causes fibroids? This is important since most of us will have them. We don't know. We do know how to cure impotence. Maybe I shouldn't say that, but we don't know what causes fibroids. So this is a really important research topic. We know how they form. It's the same process as most tumors. There's a mutation. It happens in a single muscle cell, and it allows that muscle cell to reproduce itself. And that cell makes millions and billions of copies of itself, and also pulls in fibrous tissue to make this firm, round tumor. That's why it looks like a potato. And it pushes the normal muscle neighbors out of the way. So when people say, is the fibroid in my uterus or on my uterus? It's part of the uterus. It's pushing the normal tissue out around it. Okay. So we don't know what causes fibroids, but we do know some of the risk factors. None of these is really dramatic, but they all have a small effect, we think. Birth control pills, really only if they're taken very early, age 13 to 16 is what the research says, can increase your risk for fibroids later on in life. Believe it or not, alcohol, so 7 or more drinks a week, and particularly if it's beer, will give you about a 50% more risk than someone who doesn't drink. Ethnic background, we don't know why. Black women are more likely to have fibroids, 2 to 3 times as likely. They tend to be more severe and to present earlier. Another important subject to study. Obesity, family history certainly plays a role. Most people who come to me with fibroids will at least give me one person in the family who's also had fibroids. Period that starts before age 11 is a risk. Women who've had no previous pregnancies, and the average age of fibroids is 40 to 44 when we discover them by ultrasound. Okay. So usually when we're trying to figure out if someone has fibroids or not, we'll start with an exam, and the uterus may seem enlarged, or we may not know at all from exam. But the next step is almost always an ultrasound, and the ultrasound will tell us yes fibroids or no fibroids in most cases. But if we're going to treat, we usually need to go another step. So these are additional imaging studies that may be ordered to identify where the fibroid is and whether it's a culprit for the symptoms. Sonohysterogram and hysterosalpingogram are ways to outline the shape of the fibroid inside the uterine cavity. Hysteroscopy is a procedure where we take a long, narrow camera and we actually go into the uterus and look around. Of all of these, MRI is probably the most valuable for women who are trying to preserve their uterus for fertility or because they want to hang on to it for other reasons, but the MRI gives us the most information in one shot. Now, for women whose primary symptom is bleeding, an endometrial biopsy is going to be important. We may do cervical cultures, and we may look at fertility if we're trying to save the uterus in order to allow that woman to have more pregnancies. But why would we treat or not treat? Because since we're not dealing with a cancer, that is one of the options, is to watch and wait. Generally, there's 4 questions that you would be asked or I would be asked if we're trying to decide if I need treatment for fibroids. The first one is, are there symptoms? Do you even know they're there? Have there been any problems with pregnancies? Pregnancies can cause miscarriage, early pregnancy loss. Is there ongoing risk to neighboring organs? So a uterus like you saw, the big one, you can imagine how the weight of that could compress other structures. In particular, the ureters, which are a tube that runs from your kidney all the way down to your bladder carrying urine. A big uterus like that could compress the ureter and actually block up one of the kidneys. And then is there any real concern over cancer? So anytime the number is not 0, so in this case it's a very small number that turn out to be cancers, but sometimes that MRI will make us worry enough that we say this needs to be treated. Okay. Now, I tend to work in 4s, so there's also 4 things that determine your treatment options. Again, the type of symptoms. If it's just heavy bleeding, we may go in one direction. If it's pressure and pain, we may go in a different direction with treatment. Patient factors. Are you healthy? Have you had other surgeries? Are you willing to undergo a procedure? Can you be in a head-down position for a while? These things will determine how we're able to treat and what we can offer. Plans for fertility is a big one. So if a woman comes in and says, I'm having another 3 babies, I got to do my best to save that uterus. That's important. And then the size, number, and location of the fibroid makes a difference to how we approach. Okay. Most common symptoms of fibroids: bleeding, pain, pressure, and problems with pregnancy. So the 4 Ps. I actually say periods, pain, pressure, pregnancy. If you have those things, chances are you have fibroids, or at least should be evaluated for those. Other symptoms: abdominal bulge, bloating, because the fibroid pushes the bowels up high, constipation, urinary frequency. Imagine what that heavy uterus is doing to that poor bladder. It's not giving it much room to expand. So you're in the bathroom every hour, every 2 hours. Only up to half of women are symptomatic. which seems like a lot, but on the other hand, half of women aren't symptomatic and wouldn't know the difference. So those women may not even need treatment. About 30% of women will have problems with infertility related to fibroids. Fibroids and fertility. So particularly fibroids that are inside the uterine cavity, are in the area where a pregnancy would grow, can interfere with pregnancy, can interfere with delivery and how the baby is able to turn around and go head down. Fibroids during pregnancy can cause pain. In general, that's because they lose their blood supply. The fetus in the placenta steals the blood supply away from the fibroid, and the fibroid starts to degenerate, causing pain. Women who have fibroids may be more likely to need a cesarean section, particularly if the baby hasn't turned the right way. But in general, most women with fibroids still have normal pregnancies. For a woman who is having problems with her pregnancy or symptoms, the treatment that we offer that is approved and considered safe for future pregnancies is a myomectomy, and we'll talk about that. Okay, so this is just a diagram. This is showing you fibroids, and I'm using it to, again, show you the anatomy of the uterus here. Here's vagina at the bottom. Here's the cervix, which we look at for a pap smear. That's all we can see of the uterus, is that very low part. And fibroids, we're showing you here, can really grow in any part of the uterus because they're formed from a single muscle cell. And the uterus is just that, all muscle cells. It's really anywhere. A fibroid like this, which is called a submucosal fibroid, is the kind that's going to cause trouble with bleeding and with pregnancy because it's interfering with the cavity here. So this is the part that bleeds during a period, so a fibroid that's sticking right out into that cavity is going to be more likely to cause problems with periods. And also this is where a pregnancy would develop. Fibroids in the wall here, called intramural fibroids, are going to cause cramping, and if they get big enough, pressure. Same with these up here, which are subserosal, like that white one we saw on the picture. Okay, so the imaging studies, this is an ultrasound. It's just black and white shadows. So you can see how we may be able to look at this and say, yeah, there's a fibroid, but not really be able to tell much more about that fibroid. A sonohystogram, on the other hand, here's a fibroid. Here's some fluid inside the uterus. It's telling us how much of that fibroid is inside the cavity and kind of how big it is in relationship to the rest of the uterus and whether we can take it out from inside the uterus. Hysterosalpingogram also looks at the tubes in terms of evaluating fertility, and MRI. I'll give you a better picture here. This is an MRI. You can see, if you look at this, this is the spine here. Here's spinal cord. Here's the fibroid, okay? So you can see how I can tell that there's exactly one fibroid in here. I can see how far away it is from the outside of the uterus. I know where it is in relationship to the cervix. I get a lot of information from an MRI. So from my standpoint, it's very worth the effort of going into an MRI machine because I'm going to be able to plan treatment a lot better when I have this kind of picture. Now the other thing is you can see this poor little bladder under here with that uterus on it, right? You can see why this person might be running to the bathroom all the time. You can also see up here how this big fibroid is jammed up against the spine. So anything trying to get past the spine, such as the ureters, those tubes we talked about, is at significant risk for being compressed there. So how do we treat them? Most times we're going to offer a control of symptoms first. It's the easiest thing to do. It's generally the lowest risk. Okay? If that doesn't work, we move on to other things. Now, for women who are done with their childbearing and don't have a strong feeling about hysterectomy or losing the uterus, hysterectomy is the next option. And when they look at the studies of quality of life and satisfaction, this tends to have the highest quality of life and satisfaction as compared to all the treatments combined. But it's not for everyone. Traditional hysterectomy is with the bikini cut incision that you see people get for a cesarean. On the other hand, minimally invasive hysterectomy is becoming much more common and popular. It has a lot of advantages that we'll talk about. Uterus-sparing procedures are generally radiologic procedures, and I'll tell you about those as well. Now, control of symptoms. Pain medications work well for cramping. Non-steroidal medications like Motrin, Advil, Naproxen. They work well for cramping because they block the chemical that causes cramping, which is prostaglandins. So when you take those medications, they work best if you take them on a schedule. So rather than waiting till you have pain and cramping, you say, I take it now and 6 hours later and 6 hours later, or something like that, because you're preventing the cramping versus just treating the pain. Hormones work well for control of bleeding. Not in everybody, not in some types of fibroids, but it may be worth a try if that can, save you from a surgery. Progesterone IUD generally works in the same way, which is to thin the lining of the uterus, so there's very little to come out in a period. Progesterone IUD, you've heard Mirena IUDs, they produce amenorrhea or no period in about 75% of women or a little less, but can be very successful. Now, in the setting of fibroids, it doesn't work as well, but it still may be worth a try if it's someone who's very invested in avoiding a surgery or a major procedure. And endometrial ablation heats up the lining of the uterus to burn back the cells to the layer that divides. So again, the lining of the uterus doesn't get very thick. So that's the IUD, and that's the endometrial ablation equipment. And this part goes inside the uterus to heat up. Okay. Traditional hysterectomy is removal of the uterus. It's through about a 14-centimeter incision on the lower abdomen. It takes about 2 hours in the operating room, and you stay with us about 2 to 3 days afterwards. 6 weeks of recovery because that incision has to heal strong enough that you don't get a hernia from it. Okay, ready? If you don't want to look, there's a picture. Okay. So this is a uterus, and this is an incision. Now, I'm going to show you a different picture. This is a picture from a minimally invasive hysterectomy. This is what we do when we're using a laparoscope. So this picture is taken from a camera that's through the belly button, through the umbilicus here, or a little bit above, looking at a fibroid uterus. This uterus is pretty big, probably 3 times, 4 times the normal size. Okay?
What size would you say that is?
In centimeters? Oh, probably 14 centimeters, something like that. Okay, so let me talk a little bit about robotic and laparoscopic surgery. That's what I do, so I'm passionate about it, and I think it has a lot of advantages for women. Basically, all steps of the traditional procedure are performed using instruments that we pass in through tiny incisions on the abdomen, okay, like this. So here's the uterus and ovaries in tubes. The instruments are about 5 millimeters in diameter. They go through those incisions, and we operate while watching a TV screen. Okay, we fill up the belly with carbon dioxide gas in order to give us room to operate. We can do hysterectomies that way. We can do myomectomies that way, and we can do other surgeries. Okay. Compared to traditional hysterectomy or other traditional incisions, okay, the larger incision on the lower belly, laparoscopic hysterectomies have a shorter hospital stay. Usually you're there less than 24 hours, faster return to activity, fewer infections, less pain, less blood loss, and less scar. So this is why we try to do things minimally invasively nowadays, as often as we can. Vaginal hysterectomy has similar benefits, but it's a little less applicable to the wide range of people because you can't see as high up into the abdomen. Okay. Big question. I get asked this all the time, and I think it's a very valid question. Does a hysterectomy cause menopause? And this is most relevant if you haven't already been through menopause, right? So wondering if afterwards you're going to get the hot flashes and the dryness and that kind of thing. The answer is yes, in the literal sense. So no uterus means no periods, means a pause in menses, which means menopause. So the first answer is yes, you will no longer have a period if you have a hysterectomy. But no, you don't necessarily go through the hormonal menopause that most people are referring to, and that's really the more relevant question. As long as the ovaries are functioning and they stay in, you don't go through hormonal menopause until the natural age that you would go through menopause according to your genes. Okay, now if you have a hysterectomy and your ovaries are no longer working, we can't change that by leaving them in. You're still going to be in hormonal menopause. But if they're working, they can often be left in place to provide hormones until that natural age. We remove them if we're worried about them. If they're not working, so they don't offer you any benefit from staying in, Or if they appear abnormal, we're worried about cancer or bad endometriosis. Or if you come from a family that has a high risk of ovarian cancer, remember, we don't pick up ovarian cancers very early. So if we have an opportunity, we're there, you have a high risk, we may offer you the chance to have them out and decrease your risk, okay? Or if there's pain that we can attribute to the ovaries. Does a hysterectomy ruin sex? I get asked this all the time too. The evidence says no. As you remember from the picture, the only part of the uterus that's in the vagina is that little nubbin of cervix that we look at for the pap smear. So really, after a hysterectomy, particularly the minimally invasive kind, the vagina is unchanged, other than that little nubbin is no longer at the top, okay? And for many women, what they tell me is that without the pathology, without the bleeding, the pressure, pain with intercourse, that sex is less inhibited and less painful, and so better. Leaving the cervix, which is often done, does not seem to offer any benefit. Certainly, they haven't been able to demonstrate a benefit for sex of leaving the cervix or the lower part of the uterus. And for anyone who's had abnormal pap smears or pain, it's not a great idea because we're usually back there at some point in the future taking it out. Okay. So for women who need to keep their uterus for future pregnancies or who want to keep the uterus, we offer different treatments. Traditional myomectomy or minimally invasive myomectomy, what is that? Well, we go in and we remove the fibroids one by one and then repair the uterus. So sew the muscle back together. Traditional myomectomy, a large bikini cut incision. Minimally invasive myomectomy means we either use the robot or we go in through the uterus with a hysteroscopy, or sometimes we use a really tiny incision called a mini laparotomy. I'll show you a picture of how we do it. 2 radiologic procedures are available. One is called the uterine artery embolization. They go in and they block the blood supply to the uterus and fibroids with little plastic beads, and it decreases the oxygen and nutrients to the fibroid, and the fibroids shrink. Ultrasound ablation techniques are newer but becoming increasingly popular, and I'll show you some pictures. Okay, myomectomy, removal of the fibroid. It's appropriate for symptomatic women who want to preserve the uterus. The technique really depends on the size and the number and the location. Ready? Okay. So this is a fibroid that's just inside the uterine cavity. Okay, this here is just space and fluid around the fibroid. This kind of fibroid, you could go in straight through the cervix and take that out without any incision on the belly. It takes about an hour or two. Most people go home that same day and return to full activity in 48 hours. It helps with pregnancy rates if that was an issue with recurrent loss or infertility. And complications are very low. Uterine perforation does happen. That means that we go through the muscle of the uterus. But it happens not that frequently, and usually observation is all we need for that to heal. Okay. Mini laparotomy. So we may, in this picture, this incision here is about that big, about 5 centimeters. And this patient had a huge fibroid here. We just took it out in pieces and saved her a big incision. Recovery is about 3 to 6 weeks, again, because even though the incision's small, you don't want there to be a hernia there. And this is a good option for someone who wants to preserve the uterus, who has a lot of fibroids that would take a long time under anesthesia if we did it robotically, or for somebody who scars with keloids. So a robotic procedure has 4 or 5 incisions up here where you can see them. So we may be able to hide the incision in the hairline for somebody who forms keloids. Laparoscopic myomectomy or robotic assisted, we talked about the technique. Basically, the only limiting factor is how many fibroids you have and how big they are, because we have to be able to see around them, and how long we can put you under anesthesia, because it takes a little longer with the small instruments. Okay, this is the equipment for robotic surgery. You've probably seen it if you've surfed the web at all. This is the console where the surgeon sits, so I'd put my face in there, my fingers in loops, and as I move my fingers, the instruments that are inserted through those small incisions are going to do just what my fingers are doing while I'm sitting over across the room. Okay, so this is state of the art. So how many people are here? Me. an assistant here, usually somebody down pushing the uterus up with a manipulator, a scrub nurse, an anesthesiologist, circulator, I don't know, 5, 6, 7 people. Okay. Laparoscopic surgery, it gives us 3D visualization. It allows us to move our instruments like a human hand. So you can move them in all directions at the wrist. And the big advantage is that it gives me 4 hands. So I control a camera and 3 instruments. So instead of being a 2-handed surgeon, all of a sudden you're a 4-handed surgeon. Okay. So I'm going to move past surgery. We're going to talk about the radiologic procedures for fibroids here. This is uterine artery embolization. So here's a fibroid. Basically, the technique is to come through artery in your groin. They thread up a catheter to both sides and put little plastic beads into the blood vessels, and the fibroid shrinks. It's done under IV sedation. It takes about 2 hours. Generally, you stay less than 24 hours in the hospital, and you recover over 2 to 3 weeks. It's successful for symptom control, bleeding, and pain in about 90% of women. And that's the good news. About 15% of women will end up with ovarian failure, particularly if they're over 45. We don't really know why, but we think it's because these little beads will also float up and get into the ovarian circulation and slow down blood supply there. 20% of women who have this procedure, however, will go on to need a hysterectomy anyways in about 2 years because of recurrent symptoms or persistent symptoms. So it's a great procedure. It works well for 80% of people, but if you're someone who says, this has to be the only treatment I do because I'm not going back for anything more, then a hysterectomy is probably the better option because then you're done. But this is a good option for women who can't undergo surgery also, so people who have a lot of risks from surgery. This is the newer technique. This is magnetic resonance guided ultrasound surgery for fibroids. Okay? We call it FUS because it's a little faster. In this procedure, ultrasound waves are focused to a point inside the fibroid. So you can see she's resting here. And at that point, the tissue heats up and it basically melts the fibroid. Okay? Here's without her, but here's the ultrasound melting the fibroid. It was approved by the FDA in 2004, and the studies are still going. So every year you hear about more and more people who underwent this procedure successfully. Appropriate candidates are people who have symptomatic fibroids. They're not trying to pursue pregnancy because we don't know enough about it in pregnancy yet. And they don't have anything between the uterus and the belly wall, because if you have bowel sitting there, you're going to burn the bowel, or scar. It can take up to 6 hours, and it decreases the size of the fibroid by about 40 to 50% in volume. So if you take a 10 centimeter fibroid, you may get it to about 7 centimeters. But even so, somewhere around 80-90% of women will still have successful resolution of their symptoms. But again, there's still a number of women who will go on to need more treatment. So around a quarter of women will, in 2 years, still need some additional treatment after this. The other limitation of this procedure, it's not readily available. The equipment's really expensive. So there's one in Boca. And the center up at Mayo in Rochester, I know the woman up there who's doing a lot of the research, so that's another good center if a woman comes to me and is a candidate for this. This is a question I get asked a lot, and I wish the answer were yes, but it really isn't yet. Are there medications that work to treat fibroids or get rid of fibroids, or would diet treat fibroids? And the answer is no, but hopefully coming. These are medications that they've tried, mifepristone. It seems to work, but it causes other problems like hyperplasia inside the uterus. Raloxifene is another medication we sometimes use for bone loss. It works, but you have to use it with Lupron or GRNH agonist, which also works, so why take 2 medications? And then you may have heard about Lupron or GnRH agonist, which shrinks the uterus but only temporarily. So if you're very close to menopause, it may work to get you into menopause without a lot of bleeding. But once we stop the medication, the fibroids grow back. So it's only temporarily helpful, and usually we would use it just before surgery to help facilitate your surgery or make a smaller incision. Okay. In conclusion, fibroids are extremely common. They cause bleeding, pain, pressure, and problems with pregnancy. The diagnosis is by ultrasound and exam. MRI can be very important if we're trying to preserve the uterus. And we treat if it's symptomatic, if the fibroids are symptomatic, or if they're causing morbidity or damage to other organs. And the choice of treatment depends on your symptoms, the fibroid characteristic, the number, size, location, uterine preservation, if that's desired, if that's one of our goals, and the characteristics of the woman. Most women nowadays can have a minimally invasive treatment, even with a big uterus. And a dedicated clinic may facilitate comprehensive streamlined care for the treatment of fibroids. And this is my mission. This is what I'm working on. So our fibroid care clinic, our mission is to provide and coordinate excellent, comprehensive, and streamlined diagnosis, counseling, and treatment for women with uterine fibroids. And that comes from spending a lot of my time seeing women who've put up with their symptoms for a long time. And women are likely to do that. Women put up with their symptoms because they're taking care of everybody else, right? And my mission is to say, we don't need to do that. You don't need to wait 2 and 3 years with your pain and your bleeding. Let's take care of it now. There are ways we can do it. It doesn't give you a whole lot of downtime. So I'm trying to change the status quo for women with fibroids. Okay, this is a video. I don't know if it'll play, but I hope so. This is actually one of my mentors who gave me this video, and it's just the right length to show you in a setting like this. This is a myomectomy using the robot. Let's see. Okay. So Dr. Advincula is now at Florida Hospital in Orlando. He was one of the pioneers of robotic surgery. He's one of the people that taught me initially laparoscopic skill. He's a fantastic surgeon, and this is just a nice, elegant video showing you a fibroid here, a single fibroid at the back of the uterus. And watch these instruments. You can see how they look like little miniature hands being able to pull this fibroid out. And this lady will get to go home the same day. You can see how this fibroid, this is a real-life fibroid, looks just like a potato, right? You're going to watch. After this fibroid comes out, there's a very small defect in the back of the uterus to repair. And that's it. So I'm going to go ahead and click on to the next one. Here's another little video. I'm only going to show you part of this, but I'm showing you the difference between the robotic technology. And this is traditional laparoscopy. So these instruments don't bend at the wrist. They swivel, but they don't bend. You can still do a lot of procedures this way. This is the way I was trained to do straight laparoscopy or robotics. For some women, this is just a faster procedure, or if the robot's not available in the center where they are. And a lot of what we do with minimally invasive surgery involves heat. We heat up the vessels, which basically seals them before we cut them. So there's not a lot of suture involved. And on the left, this is the uterus, if you're wondering, over here. This is a fairly big uterus, I don't know, 7, 8 times the size of normal. And we're separating out the ovary. So in this case, we're saving the ovary for this woman.
Is this like a partial hysterectomy?
People use partial, here, right, is this a partial hysterectomy? People use partial to refer to different things. Some people use it to say that the cervix was left in. But in terms of whether we take out all the pieces, it's partial because we leave the ovaries on this type of surgery, but we take the whole uterus, including the cervix, which is part of the uterus. But this woman will wake up and have the same hormone level that she did before surgery. So she won't feel differently in terms of hot flashes and such. She just won't have this big uterus that she's been carrying around. Okay. Okay, so what about me? If I'm sitting here thinking, well, I have some of these symptoms, I have bleeding, I have pain, I have pressure, I'm in the bathroom every hour, having to empty my bladder. Do those symptoms change my quality of life? They're not a cancer. Do they have to be treated? If it changes quality of life, I would argue that it's worth treating, because life is only so long. So ask your doctor to evaluate the symptoms. I can't tell you the number of times that I'm talking to a woman with large fibroids who's saying, yeah, I've been saying it every year, I've had bleeding every year, and it just kind of gets pushed off to the side. Consider all your options. Ask for minimally invasive technique. You probably are a candidate. Ask questions, read, and pursue treatments to reclaim your quality of life. And hopefully before the uterus gets to be this size, because this is a struggle for me to get out. So if you come in a little sooner, it's a faster and easier surgery for you and me. That's it. Thank you. I'd be happy to take questions. Yes, back there. The question is, do fibroids usually grow if you're in menopause? Yes, did I hear you right? Yeah, okay. Fibroid growth is fueled by hormones, estrogen and progesterone. So when you reach menopause, if you're not on hormones, your natural hormones have dropped off, right? So the fibroids don't usually grow in menopause. Now, occasionally we'll see somebody who's not on hormones who did have fibroid growth, and a lot of times that's a reason to take out the uterus because we're a little worried about that growth. But even so, it's almost never a cancer. In women who are on hormones, so you still have the hormones that stimulate fibroid growth, once you're in menopause, those levels are low enough that the fibroid usually won't grow, but it may not shrink to the level we would expect in menopause. So naturally in menopause, as your hormones drop off, the fibroids will shrink a little. And so your symptoms get less, pressure gets a little less, and bleeding goes away. Okay, but if you're on hormones, it may not shrink as much, so you may not get that benefit. Yes, ma'am?
If you have another issue, for instance, polycystic ovarian syndrome, does that make you more likely or less likely to have fibroids?
So if you have polycystic ovary syndrome or another process, would that make you more likely to have hormones? And the answer is we don't know, or at least I don't know. I have not seen that come up in the literature. We do know that fibroids are associated with other gynecologic disorders like endometriosis and adenomyosis seem to occur more frequently when there are fibroids. And it probably has something to do with the enzyme involved in the endometriosis or the fibroids. But with polycystic ovary syndrome, I don't know of a direct link. Good question. Yes, ma'am.
What about the level of insulin growth factor? Is that any different in women with fibroids?
What about the level of insulin growth factor? Is it different in women with fibroids? I don't know. There's a number of growth factors that are involved. And it's not definitive yet, and I don't know, unless something's come out very recently about that. I'm trying to remember the long list that I have of growth factors, and it's probably in there, but I can't tell you much more than that. Yeah. Yes, ma'am.
I have two questions.
Yes.
If you've had a total hysterectomy, why do you have to have a pap smear? And then, are you in any danger of having ovarian cancer if you don't have any ovaries?
Good question. Two questions. One, if you've had a hysterectomy, why do you need a pap smear? So let me answer that first. If you've had a hysterectomy and they've taken out the cervix, so remember there are certain hysterectomies where they leave the bottom part of the cervix, and a pap smear is meant to detect cervical cancer in its precancer stage. So the first thing is if you still have a cervix, even if they've taken out the uterus, you still need a pap smear. But if you've had a total hysterectomy, it depends on your past history. It depends on why that hysterectomy was done. If it was done for precancer, that effect, that HPV, that effect can also have changed the cells of the vagina. So they're actually doing a pap of the vagina to make sure we don't miss a vaginal cancer. The rest of that is, do you need a pelvic exam even if you don't have a uterus and don't have ovaries? And the answer is yes, every year, because you have other organs. You have bladder there, you have bowel, and a lot of times the GYN is the only one who's going to look at that. And the other issue is the vagina. We're checking the vagina too. So you may not need a PAP. It really depends on the history prior to the hysterectomy. If the history's been benign, we'll stop doing PAPs, but still do the exam. Okay? And the other question, remind me? Ovarian cancer. Well, could you get an ovarian cancer if the ovaries are out? And the answer is no. You won't get an ovarian cancer if the ovaries are out. And that's why we take them out if we think that a woman is at high risk or if we're worried about them. There is a similar type of cancer that looks a lot like ovarian cancer when we look inside the abdomen, and that's called primary peritoneal cancer. Taking out the ovaries doesn't prevent that kind. So every once in a while, and it's a much less common cancer, but every once in a while someone will say, I had an ovarian cancer, my ovaries were out, they must not have taken them out. And usually that's the similar but different cancer, the primary peritoneal cancer. Thank you. Yes, ma'am.
I have two questions too.
Okay.
If you have an intramural fibroid,
Mm-hmm.
you've gone through menopause, okay, and it still hasn't decreased, okay, and your uterus has increased. It's very large. Would you suggest a partial hysterectomy